here. Yeah, I'm very happy to be here with everybody today and to discuss a little bit about high blood pressure. If you can, sure. And so we'll talk about a little bit about blood pressure. Blood pressure is something that can be confusing to people at times. I know when I was getting into the medical field, it was very confusing. There's so many different types of medications and classes of medications, and it can get all very overwhelming and confusing very quickly. Okay, so we'll just cover some objectives first today. We're going to understand what blood pressure is. We'll talk a little bit about the history of high blood pressure. We'll become familiar with the risks associated with untreated or high blood pressure, and have a basic understanding of the different kinds of blood pressure classes and medications. We're going to review the current recommendations for blood pressure goals for stroke risk reduction. So the history of hypertension or high blood pressure. In the early times, high blood pressure was known as hard pulse disease. The common treatment was bloodletting or leeches, a very kind of primitive treatment for high blood pressure. But then in the 1600s, there's a little bit more study of the cardiovascular system and understanding of the circulation. And in the early 1600s, our knowledge of blood pressure became a little bit better. And the first published measurement of blood pressure was in 1733. So we've been monitoring blood pressure for a long time, but the treatments of blood pressure are actually fairly recent. It was first described, hypertension was first described as a disease in the early 1800s. In 1896, the blood pressure cuff was invented. They call this a sphygmomanometer. Hypertension really, and with the invention of this, we can easily get an objective blood pressure. Hypertension really very much became more familiar to physicians. But it wasn't until, but there's really no way to treat it. And even with as we started identifying a high blood pressure as a disease, it wasn't universally accepted. There were some people that didn't think that high blood pressure was all that bad for people. And so as far as treatment, it wasn't until after World War II that we started finding treatments for it. And so just to describe to you a little bit about how blood pressure was viewed by people who didn't think blood pressure was a problem. Here's a quote from a physician. There is some truth in saying that the greatest danger to a man with a high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. So you can see that while hypertension had been identified as a disease process, it wasn't really universally accepted even as early as 1931. So we've come a long way since. So what is blood pressure? Blood pressure, or as we call it oftentimes here in the medical realm, BP, it's the actual pressure of the blood against the walls of the arteries. And it measures two numbers. It measures the maximum pressure when the heart contracts or when the heart is beating. And also there's a measurement taken when the heart is at rest. So as we see, the first or top number is what we call your systolic blood pressure. And it's the highest level your blood pressure reaches when your heart contracts and pushes that blood out. And then the second or bottom number is what we call your diastolic blood pressure. It's the lowest level that your blood pressure reaches as your heart relaxes in between the beats. A normal blood pressure is 120/80. So that's usually, unless you have some other disease process that we have to take into consideration, usually we like blood pressures to be around that 120 to 120 to 80 range or less. And typically, one thing I'll tell you from a stroke perspective, we like that top number. It has to do with stroke. So we are very concerned with that top number here when we're seeing patients in the hospital. The bottom number is much more of a cardiac important number. So those are the kind of, when we look at stroke or heart problems, that's how that blood pressure that's how we look at it differently. So the top number is more concerned for stroke. The bottom number is more concerned for cardiac health. The higher your blood pressure goes, the higher your risk of health problems. For example, I have here, if your blood pressure is 135/85, that doesn't sound that bad of a blood pressure. And a lot of people would consider that normal. But someone with this reading is twice as likely to have a heart attack or stroke as someone with a reading of 115/75. So you can see how very, very quickly the higher your blood pressure goes, the higher risk that you start assuming for health problems. Besides stroke, if you have untreated or poorly treated hypertension, it can cause all sorts of problems. It can affect almost every system in your body. We talked about the heart and heart disease. It's definitely a big problem with heart attacks. Heart failure, so not just causing a heart attack, but also causing heart failure. Eventually, sometimes the pressure can get so much that your heart no longer can pump well enough to move the blood through that to overcome that pressure gradient. Kidney failure. You have your kidneys are your filtration units for your body, and all the blood is going to circulate through your kidneys. And if you have high blood pressure, that can certainly cause kidney damage, as that high pressure translates to those very fragile capillaries and blood vessels that are in your kidneys. Dementia, so it can cause long-term brain problems. It can cause what we call white matter disease, where in your brain, where high blood pressure over long periods of time can actually cause these very tiny micro strokes. And you're not going to know that you're having those micro strokes because it happens over very long periods of time, but eventually it starts affecting so much of your brain that it can start causing you to be confused, having altered memory and personality changes. And vision problems. Your eyes are very susceptible to high blood pressure, and it can certainly affect your vision. It can damage artery walls. If you've heard of atherosclerotic disease or atherosclerosis, it's a hardening of the arteries. That high blood pressure will affect the inner lining of those artery walls. It can also cause sleep disturbances. Not something that we see a lot of, but it's definitely possible. And so when we look at stroke, we look at some of the risk factors that we can control. Okay, so there are certain risk factors that people have that we can't really control, such as race is a big one. The African American community carries a higher burden of hypertension than the Caucasian community. So while that's a risk factor, it's nothing we can control. And so what I want to do is really kind of cover these modifiable risk factors, those risk factors we can control, so that we can keep you in the best health possible. So high blood pressure is the #1 risk for stroke. So we take blood pressure management very seriously here on our service. Cigarette smoking is the second highest risk factor. So we, when people come in, we absolutely will look at if they're a smoker or not. Smoking can harden the arteries. So we really try to coach people at quitting smoking, and we will always have this smoking cessation team come and talk to them about ways to stop smoking. Diabetes, high cholesterol, irregular heart rhythms, being overweight or a lack of physical activity, poor diet, and sleep apnea, where you have trouble breathing when you're sleeping. Your breathing can stop for periods of time. And so these are all risk factors that can contribute to stroke. And when you come into the hospital, we address all these. All these risk factors we look for, we address whether if it's if you lead a very sedentary lifestyle, we'll do education on physical activity. If you have high cholesterol, we'll start you on medications and diet changes to help get your cholesterol in control. If there's concern for sleep apnea, we have you meet up with our pulmonary or neurology group that are the sleep specialists. So when you come in, we address all these risk factors. But today we're really kind of focusing on the hypertension or high blood pressure. And so when we look at that, the best thing to do is to put you on a medication. And nobody likes medications. It's a pain. It's expensive. It's just something people would rather not do. But unfortunately, for many of us, there's no other better way to help control blood pressure. I wanted to talk about the different types or classes of these different medications. First kind of overall class would be diuretics. So what diuretics do is they reduce the circulating fluid volume. So these are what you would call your water pills. You want to take them in the morning because you're going to be urinating a little more often through the day, and you don't want to take it at night because then you're going to be urinating at night. But it decreases the volume, the fluid volume within your blood. Okay, it's very common to be put on one of these. There are some side effects with these, though. It can mess and affect your sodium levels, your potassium levels. So all of your electrolytes can be affected by diuretics, and it can also cause dizziness and even fainting if you get too dehydrated, or if the medication is not of the right dosage. Within the diuretic family, we have loop diuretics. This is the most common type of diuretic, and the most common loop diuretic is what we call Lasix. So these actually affect the action of Lasix actually affects the kidneys to help you pass more water. We have potassium-sparing diuretics. These are diuretics that they still help you pass more water, but you don't lose as much potassium in your urine. And so some of the common ones that people might be familiar with are spironolactone, which is very familiar, amiloride, and triamterene is a popular one I see pretty commonly. And then there's thiazides. Hydrochlorothiazide is the most common diuretic. We use it a lot, and it's one of the first ones that they came out with, and so it's just been such a great medication for so many years. However, it can cause high blood calcium. Again, we have to watch your electrolytes. And often, anytime someone's on a diuretic, usually we have them take some potassium supplements, just to be safe. If you get really low potassium, that can affect your heart health. The next class of blood pressure medications we have are beta blockers. And beta blocker receptor sites are found in the heart and kidney. So these are little receptor sites that they like to attract a drug called epinephrine and other stress type hormones which will increase your blood pressure. It'll cause your blood vessels to constrict. And so if we give you a beta blocker, what that does is it interferes with the binding of those stress hormones. That way your blood vessels don't become restricted. Propranolol was the first beta blocker that was developed in 1964. We still use that a lot. In fact, it was described as one of the greatest contributions to medicine in the 20th century. So it was a very good drug. The beta blockers are very common drugs that we use for blood pressure control. And so I have some of our common beta blockers that you might recognize. Obviously the propranolol, but we also have carvedilol, labetalol, sotalol. So pretty much any of your medications that end in OL are going to be a class of beta blocker. And they're usually pretty well tolerated by people as well. The next class we'll look at are calcium channel blockers. And calcium channel blockers help relax large blood vessels that contribute to those high blood pressures, specifically the top number, your systolic pressures. And so what they do is they affect the vessel walls directly and allow those blood vessel walls to relax. Okay, and these are less common. They're much more specific things that calcium channels or blockers are often used for. But for people that have really difficult blood pressure, they can certainly be placed on a calcium channel blocker. However, there are more side effects with these. While beta blockers don't have a whole lot of side effects, outside of, like, the biggest one for a beta blocker is slowing your heart rate, which can lead to dizziness. But calcium channel blockers have more side effects, such as it can cause constipation, dizziness, fluid buildup in the legs. It can cause headaches. It can affect your heart rate. So you have many more side effects associated with this. And that's why it's not typically one of the first line drugs that we use for blood pressure management. Common calcium channel blockers are amlodipine, nifedipine, felodipine. All of your pines are your calcium channel blockers. And so amlodipine is probably the most common one. It's typically not, like I said, not a first line agent, but we'll use it more commonly than the other. Another class is angiotensin converting enzyme, or ACE inhibitors. Angiotensin is a very potent blood vessel constrictor, and the ACE inhibitors will block that angiotensin from causing those blood vessel walls to constrict. So it makes them relax. Those vessel walls relax. It can also increase urine output. So typically another medication we take in the morning. And common side effects, probably the most common one is a cough. And anytime someone gets put on an ACE inhibitor, usually the physicians are going to warn you about, you may have a little bit of a cough with this. It can also cause high potassium, headaches, and dizziness. And our common ACE inhibitors are enalapril, captopril. So lisinopril is probably the most popular. Benazepril is also a popular one, but all of your prils. So if you notice, all these classes of medications, they have very similar endings in each class. And so knowing what the last part of your medication is called can clue you in on what sort of class medication you're on. Then we have angiotensin II receptor blockers, or ARBs. These prevent the binding of angiotensin II to receptors and also allow relaxation of blood vessel walls. these are usually, if you have a lot of side effects to the ACE inhibitors, the coughing is probably the most common one, then oftentimes we'll move you over to an ARB, because it works in a very similar fashion, without the same side effects. Not to say that it doesn't have side effects, because it does. A dizziness and a headache. This one can give you some muscle pain. It may cause some insomnia, but you don't get the coughing associated with the ACEs. Some common angiotensin 2 receptor blockers, or ARBs, are losartan, valsartan, diovan, olmesartan, or Benicar. So we see those medications as well. And so you have all these options, and so what we do is we usually will start with usually one agent, and once that agent gets maxed out, then we can start a different agent. And the whole point of this is to really get your blood pressure under a very safe level, so that we can reduce your risk of stroke. And so what we typically like is a systolic blood pressure less than 130 to reduce stroke. It also helps reduce myocardial infarction or heart attack, heart failure, and other cardiovascular events like we discussed earlier. Usually, it used to be that the thiazide medications were kind of we started there first, like the type of diuretic. But they've done studies and they found that nothing was better than the thiazide-like diuretics as a first-line therapy for any outcome. So you see that started initially first. Besides medication, what else can you do to lower blood pressure medicine, which is a very popular question? Exercise. Exercise is extremely important. I personally know that when I don't exercise, my blood pressure is higher. So I have personal experience with that. So and to exercise, you don't have to go to the gym and run 6 miles and lift a whole bunch of weights. This can be something as simple as getting on a daily walking schedule and walking a mile or two, maybe doing just some very light, like the resistance bands or something, or step ups. It doesn't have to be a full-blown exercise regimen. It can be very simple things that you do every day that can assist with lowering your blood pressure. That will also help you lose weight, which is another risk factor for blood pressure, and can eating healthy and doing exercise can go a long ways for that. Stopping smoking, I probably should have had that one first, because that's the biggest one. If you smoke, you really have to work on quitting, and if you smoked previously, oh my gosh, don't start now. So smoking is important. And then, like I said earlier, eating healthier, that goes along with the losing weight. There's, I'm sure the foundation probably has lots of pamphlets and information on how to eat healthier. I think we all know it. We just don't like eating our greens. But having a balanced diet, I think, is the most important part of that. Doesn't mean you have to not eat anything except for vegetables, but you just need to be balanced and watch portions. Not adding salt to food is important. Salt will help you retain water in your bloodstream and contribute to higher blood pressure. So we always have people do salt. What's the word I'm looking for? But like what is that one called, Sarah? What's that? No, so there's some salt, different like Dash. Yeah, Mrs. Dash is a very good alternative to salt that provides you some of the salty taste, but it's not actually salt. So, uh, so very, very good little things that you can change. Monitoring your blood pressure daily is very important. And I wouldn't just check it once a day. I would probably check it once in the morning and once either in the afternoon or evening, because throughout the day, your blood pressure can fluctuate. And what we usually have our patients do, especially if blood pressure is an issue for them, is we have them keep what we call a blood pressure diary. And so each day they take their blood pressure twice during the day, and they'll keep that diary until they come see their primary care doctor, because getting your blood pressure just taken one time at the doctor's office doesn't give you a complete picture of the status of your blood pressure. So keeping a blood pressure diary will help immensely with that, especially when your doctor goes to make changes to your medication. And then following up with your doctor regularly. So really all these things are like, it's like a daisy chain of getting things done. Everything's kind of builds on top of each other, so that you can really kind of improve that health status. Now, one thing I will say is that if you do everything right, you do everything right with your blood pressure, and every time you check your blood pressure, it's 120/70. That's not going to eliminate your risk for stroke. It just reduces it. So we have had people that have had strokes with regular blood pressure, but it's very rare. Okay, so just keep that in mind. We want you to lower your risk of stroke as much as possible, and blood pressure is the single number one thing you can do. And so, while it won't eliminate your risk of stroke, it will certainly reduce it significantly. This is our Be Fast. This is, if you remember our FAST, the American Stroke Association had the FAST campaign, where it was FACE is one side droop, ARM is one side numb, speech is it unclear or slurred, and T was time for calling 911. We've also included balance and eyes, because the FAST moniker really kind of just looked at strokes in certain parts of the brain. And as we add on the balance in the eyes, then we add on more of parts of the brain that are more in the back side of your brain that are very important and sometimes overlooked. And so B is for balance. Are you having difficulty with walking or sitting up straight, or are you having clumsiness? And then the eyes, are you having vision problems? Usually it's going to be double vision, or it can be you're missing certain parts of your vision. And so adding this to the FAST thing it just helps cover more bases. It makes you more knowledgeable about what might be a stroke. And then stopping strokes, reducing the risk and acting fast. If you look in the center, my stroke stopped here, because time is key. Prevention, knowing your numbers, specifically, your blood pressure numbers, your cholesterol numbers, making sure that you're following along with your secondary prevention. And secondary prevention is what we're doing, because secondary prevention is preventing a stroke after you've already had one, okay? And then acting fast. And make sure that we absolutely call 911 if we start having stroke-like symptoms. I'm not sure which ones of you were able to get here in time where you could get our maximum medical therapy, but it helps, and you have a much better chance of recovering if you get here as soon as possible. Okay, does anybody have any questions? I know this is not an exciting lecture by any means, but it's something that probably affects each of you in one capacity or another. And so it's very important that you have some basic understanding behind high blood pressure and its treatment.